So I am going to talk about how managing a twin birth is different than managing a singleton birth in the different stages of labor. So for the first stage of labor, one of the things we're going to do differently is we're going to monitor heart tones more frequently, every 15 to 20 minutes as opposed to every 20 to 30 minutes. Additionally, we need to ensure that we are monitoring both babies' heart tones accurately. So we will use 2 Dopplers and listen simultaneously to both heart tones from each baby. Additionally, we will increase our birth team to include 4 midwives as well as an experienced birth assistant. And lastly, we will make sure that we have double the equipment, especially resuscitation equipment. We need to have a set for each baby. So, 2 bag of masks, 2 oxygen tanks, sets of tubing, suction equipment, hats, heating pads, etc. In the second stage of labor, we will monitor heart tones with every contraction. And then when baby A is born, we will immediately clamp and cut the cord to prevent any complications in the event of twin-to-twin transfusion. And we will use 1 clamp on the baby side and 1 clamp on the placental side. So after the baby's born, baby A is born, then we will listen to baby B's heart tones for at least 3 minutes, as well as palpate for fetal lie and presentation. If the baby is in a transverse or oblique lie, we can attempt to gently move the baby into a longitudinal lie, preferably vertex, similarly to how we do an ECV. We will also rule out cord prolapse by performing a vaginal exam, and we will assess the client's heart rate and blood pressure, because we know that a rising heart rate and dropping blood pressure would be indicative of could be indicative of a hemorrhage. And then if we note distress in baby B and birth is not imminent, so maybe there's no contractions or the baby's not presenting yet, then we would perform a breech extraction, whereby I would put my sterile gloved hand up into the uterus, grasping both of the baby's feet and then pulling them feet first through the vagina, and I would instruct the client to push as the feet are emerging. If there's no distress, then we can proceed as normal with the birth of baby B, monitoring closely for signs of complications, including hemorrhage, placental abruption, cord prolapse, or malposition. We would expect baby B to be born within an hour of baby A. If baby B is not has not been born within an hour and there is no distress from the baby or the parent, then it may be appropriate to continue expectant management of baby B's birth. But a shared decision-making conversation should be initiated to decide when it would be appropriate to transfer to the hospital for assistance with baby B's birth, if it's been an hour or more. Then once baby B is born, we would be prepared to perform NRP, as baby B often requires a little help getting started. And when it's time to clamp and cut the cord for baby B, we'll use 2 cord clamps on the placental side and 2 on the baby's side to distinguish baby A from baby B. And for a third stage, we could consider active management to reduce the risk of postpartum hemorrhage.